Welcome, and thank you all for joining today. I'm Cynthia Cox with the Kaiser Family Foundation, and I'm joined here with several experts who are going to be discussing how the COVID-19 pandemic is affecting our healthcare system in the United States. So we're going to be talking about healthcare costs, premiums, utilization, and healthcare outcomes and disparities as well. We're going to be looking forward to the coming year and beyond. So as I'm sure all of you know, COVID-19 has claimed over 200,000 American lives and sickened millions more. It's also caused a lot of disruption to our healthcare system. We've seen frontline healthcare workers having to scramble to expand ICU capacity in hospitals. A number of hospitals have also postponed or delayed elective procedures. And also we're seeing a move on the outpatient side towards telemedicine. And then, of course, on the enrollee and the insurance side, we know the struggling economy has threatened to disrupt health insurance coverage for those who are losing employment. So today we're going to start our presentations with two of my colleagues here at KFF. Kritika Amin will start by laying out a framework for how to think about healthcare costs during the pandemic. Then Nisha Karani will give a preview of the pandemic's effect on health insurance premiums in the individual market for 2021. Then we're going to turn it over to two researchers from IQVIA, Luke Greenwald and Michael Kleinrock, who are going to share some of the latest data on the payer mix as well as on healthcare utilization and telemedicine trends. Third, we're going to hear from two experts and physicians at Epic, Doctors Christopher Mast and Nicole Quick, who are going to share some insights using Epic's electronic health records data with a lens towards how the pandemic is going to be affecting healthcare outcomes and health disparities in the short term and the longer run. After a brief Q&A, we'll then hear from Jay Wan at the Peterson Center on Healthcare, who's going to give us some closing remarks. So as you all know, you can submit questions. We'll go to the next slide to show you how to do that. You can submit questions during the presentation, so don't be shy to go ahead and submit a question while everyone is giving their presentations, and then we'll save some time for Q&A after the presentations are done. So without further ado, I'm going to turn it over to Kritika.
Thank you, Cynthia. I want to first talk about the uncertainties that still exist in thinking about the future of the health insurance enrollment premiums and costs. Any costing and projection models that folks have tried to put together thus far have become outdated very quickly. And that's because there are a lot of moving targets here. We're still learning about the science and epidemiology of COVID-19. This makes the future of testing, vaccines, and treatment development an even more of a moving target. The medicine community is learning more about the severity manifestations, treatment, and management. We know a bit more on the rough percentage and demographics of folks likely to require hospitalizations. On the public health and policy response side, we've seen that mandates by state and local governments vary by a lot. How individuals and private firms are responding to local policies also varies. And these two things are also very closely linked in that the response is also affecting the policy setting. While local and state governments have stepped up in this incredible way, it's unclear how long state and local budgets can sustain this. State governments might have lost tax revenue of up to 25% during the height of unemployment. And so it is still unknown how the economic impact will shape the state and local efforts. All of these uncertainties affect how carriers are rating for the future. The team here will go into what the issuer said about the individual market rate filings for 2021. But what is unclear at this point is how overall spending and utilization will be affected by these uncertainties. So for example, testing is up, but should there be more testing as communities try to open schools? And then how frequently should testing be done for each person? KFF has done estimates of the cost of pneumonia hospitalizations with and without ventilators, but we don't know how much treatments, including those undergoing trials, currently will cost, and then how many in each market will need the various treatments. There's also been this historic drop in utilization across the board, including for emergency services, but there are outstanding questions on this too. So for procedures that have been delayed, there's a question on if there will be pent-up demand or just a backlog with higher wait times, particularly for elective stuff? Also, will there be longer term effects for those who delayed care? We don't know. We also don't know if those who were infected and became severely ill will have complications into the future. There are also questions on the coverage churn. How will individuals who lost coverage approach enrollment and utilization? Will they be more or less price sensitive? It's unclear at this point. So for the actuaries and forecasters, these are just a kitchen sink full of unknown assumptions at this point. Next slide, please. And so policy changes in this environment are really moving targets too. Telehealth is a good example of this. Medicare has expanded reimbursement for telehealth services, and as recently as Thursday last week, they expanded this list. Medicare has also said they'll pay for audio-only visits where individuals don't have access to video. And they've also signaled the telehealth payment changes are here to stay, at least to some extent. In the individual and small group markets, payments are not regulated like they are for Medicare, but through the risk adjustment program, CMS has offered incentives for carriers to also pay for virtual e-visits and audio-only services for at least the duration of the pandemic. Look, there are all these unknowables for 2021. That's why legislative options like the risk corridors could be useful to provide both upside and downside bumpers to MLR for carriers. One example of the unknowns that issuers might not be able to plan for right now is the Supreme Court case, California versus Texas. This case has the potential to throw coverage into complete chaos, for lack of more technical term. At a high level, there are all these other policy questions that are moving targets. I'm happy to go into details during the Q&A if there is an interest, but for now, I'll turn it over to my colleague here to talk about the rate filings.
Thanks, Kritika. But for now, the ACA is still the law of the land. So we've continued our annual analysis looking at changes in premiums on the ACA marketplaces heading into 2021. Overall, we found that premiums for ACA exchange plans are set to increase very modestly by a median of 1.1%. So far, insurers in the individual market have remained profitable and the loss ratios have been pretty low. So this isn't entirely unexpected. But of course, there is variation by insurer. About half of proposed rate changes fell between a 3.5% decrease and a 4.6% increase. We also scanned all of the rate filings for information about how COVID-19 would impact rates. To note, many of the rate filings had redacted portions of their narrative, but regardless, from what we could read, about 43% of filings specified the effect of COVID-19 on the rates for next year. Out of these, the median impact was at a net 0%. Half of rate filings specified a COVID load on premiums to be between 0% and a 2% increase. Again, keep in mind that portions were redacted. Next slide. Perhaps the most relevant part of analyzing the rate filings was to see exactly how insurers are accounting for the impact of COVID-19. In short, the term uncertainty came up a lot. For example, take this quote from an insurer in Ohio. Given the level of uncertainty and range of possible outcomes, we are not including an explicit factor for the impact of COVID-19 on our 2021 premium rate development at this time. So because of this level of uncertainty, some insurers refrained from projecting a COVID load on their premiums. While in some cases, like the state of Connecticut, for example, state regulators directed insurers not to apply adjustments from COVID. With that being said, many filings still noted the ways in which COVID-19 would place both an upward and downward pressure on healthcare costs in 2021. So as you can imagine, direct costs for COVID-19 testing and treatment were generally noted to increase health costs in 2021. But again, we saw some variation in this as well, since some insurers in regions with low rates of COVID did not need to adjust for treatment costs to the same degree insurers in a hotspot region might need to. Some insurers assumed that a COVID vaccine would be ready next year. Not all insurers publicly shared their assumptions, but in one case, an insurer estimated a $75 cost per dose of the vaccine, with 80% of the population receiving vaccine. So this factored into their COVID load. Other insurers were a little bit more conservative in factoring in potential vaccine costs. One of the most common factors that insurers cited was the impact of the pandemic and social distancing measures on the use of care, since non-emergency and elective healthcare services had drastically reduced or been cut in the early stages of the pandemic, as Kritika mentioned earlier. However, insurers often had different takeaways from the effect of deferred care. Some insurers projected that utilization would bounce back by the end of this year, and so costs would be at normal levels next year. Other insurers projected that utilization would remain this low this year, and that pent-up demand from deferred care would carry over into next year and increase costs in 2021. Some insurers anticipated that the deferred care would increase morbidity from chronic conditions and increase costs next year. And on a related note, some insurers also increased morbidity and mortality adjustments from COVID-19 specifically. And finally, a handful of insurers included a discussion about the impact of the economic downturn and resulting job losses on enrollment in the individual market. So a few insurers, and in their rate filings, described shifts in enrollment from employer-sponsored coverage to the individual market and or potentially Medicaid or the uninsured group. So to sum it all up, insurers made the whole range of assumptions of the impact of COVID-19 on healthcare costs in 2021. So there's a lot up in the air heading into 2021. And with that, I'll hand it over to Luke Greenwald from IQVIA.
Great, thank you. And everyone, thank you for joining us this afternoon, this morning, wherever you are. Just want to thank Kaiser Family Foundation for hosting this forum, as well as my co-panelists here for taking time out of their day and presenting through this information. So taking a step back and looking and seeing what's happening here from an economic perspective as it relates to what consumers are doing as they're moving through different channels of insurance. When you look back to the beginning of February of this year, we move as a country from historic lows in unemployment to very quickly historic highs. The green on this is looking at continuing unemployment. The dark blue is looking at new jobless unemployment. And if you remember back to where we were sitting at the end of March, we began to see this huge spike of people who moved out of the workforce as we went under quarantine, peaking at about 6.9 million people per week on new unemployment. By way of historical comparison, prior to that, October 1982 was the previous high at about 685,000 people with new initial unemployment claims. So literally a tenfold increase, an order of magnitude higher to what we're seeing this year. Now, as that's beginning to come down here through the summer, you begin to see unemployment rates improving, the new unemployment claims beginning to level off around that 1 million mark. But here we are in mid-October, sitting where we're seeing many parts of the country with rising instances of COVID-19 and beginning to go into additional lockdowns. So we're beginning to see some movement in this number as we head forward. So this is a great leading indicator to what do we think is going to happen from a payer channel mix. If you go to the next slide, please. So some of the questions that we field is, why haven't we seen a faster move into Medicaid since we saw this huge spike in unemployment claims happen over the summer? Well, if you look historically at the last two recessions, going back to September 11th and the housing crisis of 2008, you can see where the channel shift begins to peak anywhere from 18 months to 24 months post-peak unemployment rate. So as we follow what's going to happen here between now and the end of the year and potentially into 2021, following and seeing where this peaks, that's going to give us a good idea as to what that Medicaid enrollment is going to look like some point in the future. Now, already we're beginning to see shifts in employment occur. If you go to the next slide. When we look across the entire prescription universe, we're seeing shifting of consumers as they move in and out of these different payer channels. Indexing everyone to where they were in Q1, so what was the most prevalent payer channel that they used, i.e. commercial, Medicare, Medicaid. Here we're looking at those who are switching out of commercial insurance by expansion states versus non-expansion states. And a couple of interesting things begin to emerge. Overall, the switching rate may not be as big as what people were anticipating at about 7.5%, although it's growing. When you look at where those patients are going or where those consumers are going, you see about threefold likelihood of going into Medicaid at 23% in expansion states versus non-expansion states at 8%. So we're already beginning to see a change in velocity based off of where you might live and the insurance options that you might have. Incidentally, the health insurance exchange, while we do see some patients switching into these at about 4%, we know that there's limited options that's available. So we see more patients switching into these other channels. The other side of this graph, looking at the kind of the gray side, it's not just that we're observing more patients switching between payer channels. We're also observing more patients sitting on the sidelines, not showing any prescription activity. Now that's concerning in and of itself, particularly as we go into the latter parts of today's presentation. But when you look at this as compared to 2019 versus 2020, you see anywhere from 20 to 25% more consumers sitting on the sidelines and not in the healthcare market than what we did last year. And with that, I'm going to go ahead and turn it over to my good friend and colleague, Michael Kleinrock.
Thanks, Luke. So one of the things that Kritika suggested at the beginning and that Luke has pointed to so far is something that might happen to sort of demand for health services. And so on the left-hand side of this chart, we have a trend on the total visits. And what we've done is baseline this to the first 2 months, about 8 weeks of this year, just to get an idea of the relative scale. And we had to do that as well, partly because if you try to look at the growth of telehealth, it's so dramatically high from background and almost invisible to sort of 8–10% of the overall visits. What we do see is that sort of immediate shutdown, sort of hibernation that the whole system went through March and April, start to return to a steady state sometime by June, with a good 10% of that coming from telehealth, which is helpful. One of the questions that was asked and is often asked by all of you is, what do we get? Are we going to start catching up from these missed visits? And what you can see here is that we're tracking at sort of 80–90%. So we're not yet over 100% in any of these periods, which means we're not catching up. And so one of the questions ultimately is, are some of these visits sort of nice to have over use of the system? There's always some suggestion that there's some of that going on. Also, as you've suggested, if there are fewer if there are fewer elective procedures, then there may well be fewer follow-up visits, and so there can be an effect of that takes some of the volume out of the system. Generally, what we've seen is sort of the anecdotes from providers is that they really worked with telehealth to get most of the high management patients seen in some fashion. And they've been generally spreading visits out for the sort of logistics of how do we do infusions in a COVID environment. And for cancer patients, we've seen significantly in management patients, so diagnosed patients generally treated and back to normal. But the foregone diagnostics for cancer is something we studied a lot, and generally sort of basic overall trends. If you look at the right-hand side here, the elective procedures, this is something which is key, obviously, both from a provider economics perspective, which is, how do you run a business when you lose 3 months of your year? But also from some of the trends we've seen on prescriptions that Luke and I have been studying. One of the issues is that if you are not going to have the elective procedure, you're not going to go home with some antibiotics and some pain medicines because you didn't need them. We have seen some indication that some patients getting an elective surgery, say for something painful, like a hip or a knee replacement, may be getting prescriptions prior to the procedure in order to sort of get them to the window where they can be served. So there are some interesting adjustments in data analytics we have to do, but generally as we look at these trends, the sort of the key element that we're seeing is that we're basically still tracking behind where we would have been. Next slide. So one of the things that we were particularly concerned or interested about is some of the prevention that would normally happen in the system. So, less about sort of management of lots of chronic diseases or acute therapies or so on, But specifically, if we're looking at pediatric vaccinations for children, essentially what we notice is sort of a 3 or 4 week disruption and then a return to normalcy. In the middle, adult vaccinations, we see that dropping off with a slightly wider shark bite, as you see that, and returning more to normalcy there. But on the right-hand side, and this is where I have some sort of sign of positivity here. So, a lot of health experts, particularly around COVID, and providers have been suggesting that we really need to make sure we don't have a flu season this year to deal with any third wave and overwhelmed health system that could come from that. And what we're seeing is a significantly higher rate of seasonal flu vaccinations this year than last year. And, as a guide, the last 3 or 4 years, we've been trending up in terms of how many people are getting vaccinated for flu. So this is already on top of a strong rate. It's an even stronger rate. So this is heartening. We'll have to see how this plays out through the season, and whether some of the patterns we've seen from Australia, which is sort of precedes our flu season, that have had a weaker flu season. Again, if we're all staying home and we've not seen a real human being in person since March, it's hard to infect each other with flu. But the vaccinations will definitely help, particularly those at-risk populations. And so that's really some of the thought we have, is that the system appears to be learning how to walk and chew gum, learning how to manage COVID in this environment and still deliver necessary healthcare for other people, which is a positive. But there's still that lingering issue of the sort of the where did they go people that we see sort of a month or 2 months worth of significant absence of normal patient flows. And those are definitely a concern going forward, particularly if we remain at this sort of sub-baseline level through the rest of this year and into 2021. And that could have longer term impacts on chronic disease outcomes and prevention. And so definitely worth watching, and definitely vote in favor of some of the outreach communication and TV ads that you're seeing about sending your kids for wellness checks and people going back to the doctor. Those are definitely positives in light of these sort of lingering absence of patients. And with that, I'm going to hand over to my good friend, Chris.
Thanks, Michael. Really interesting stuff there, by the way. I'm going to build on that a little bit. Hi, everybody. My name is Chris Mast. I'm one of the physicians on the clinical informatics team here at Epic. The Epic community has come together over the last number of months here in 2020 to pool information, both in the short term to address COVID-19 specific questions, and over the longer term with a project that's called Cosmos. These overlapping initiatives each currently represent many millions of patients. So today, Nikki and I are going to share a few findings from those projects that put some additional concrete numbers around the issues that the team is discussing today. If you're interested, you can do some more reading at the Epic Health Research Network website, ehrn.org, for more findings from Epic community members and our own internal research group. The first finding I'd like to talk about describes the effect of the pandemic on routine cancer screenings, specifically for breast, colon, and cervical cancer. And you can see that here on this graphic. Back in the onset of the national emergency, cancer screening understandably dropped precipitously, between 86 and 94% below the historical levels, as you see there on the graph. That was likely due partly to health systems, where, of course, the scramble to get processes and PPE and so forth in place meant that they temporarily had to alter clinic access. And of course, it's partly due to patients who may not have felt safe going to the clinical setting for things like routine screening. Screening levels gradually, as you can see, trended back to baseline over time, but that gap, which is highlighted in sort of that maroon red area there, created a sizable deficit of missed screenings, as Michael mentioned, for the immunizations. So between mid-March and mid-June, some 285,000 breast cancer screenings, 95,000 colon cancer screenings, and 40,000 cervical cancer screenings that otherwise would have taken place didn't. And the risk there is obvious: missed diagnosis or delayed diagnosis of cancers, resulting in more advanced disease before detection and treatment. Next slide, please. And as we saw in a previous slide, a similar thing took place with immunizations, in this case, pediatric immunizations. And you can see them split up here by age group, and you see that same drop for immunizations in each age group that we saw for the cancer screenings. Now, this particular analysis was done a few months ago, and in particular, we saw that between early March and early May, an estimated 260,000 immunizations were missed or delayed. And as with cancer screenings, those numbers have trended back towards baseline over time. But of course, the concern is that baseline doesn't mean that we're necessarily catching up with all of those missed immunizations. In fact, some organizations have told us about how they've taken this finding and used it as a stepping off point to identify the patients who are at highest risk, and then aggressively getting them caught back up. And you can see that in particular here, that took place quickly for the patients who are under 6 months, but it needs some more aggressive attention as patients get up into the above 18-month range there, as those levels are slower to come back up towards baseline. And of course, there's that catch-up issue that Michael pointed out very clearly. Now, Nikki's got some other interesting findings that can also be found on EHRN, so I'll hand things over to her.
Thanks, Chris. I want to end the presentation with a brief discussion of two studies that we were actually fortunate enough to partner with KFF on. The first of which is trends in overall and non-COVID-19 hospital admissions. Now, this study is actually just released today. Some of the key findings of this study were that hospital admissions dropped to as low as 68% of predicted admissions, and this was found during the week of April 11th. This trend did sort of go back almost to 94% of predicted levels by July 11th, and then of August 8th, the admission volume has decreased again to about 90% of predicted levels. Very important to note that this sort of decrease in declines in hospital admissions represent about 6.9% of the total expected admissions for 2020. So this is a significant number. Also, another important sort of subgroup that we looked at in this analysis was people age 65 and older. And they had about half as many admissions in late March and April compared to what was predicted. And their visits, as far as where they've come to in August, have only come back up to about 80 to 85%, whereas we've seen everybody else together come up to about 90%. So what does this mean? I think another big question mark, to be honest. Overall, hospitals are seeing a significant decrease in admissions. Will this then get worse as we see spikes of COVID? Sort of to be determined on that, but something to take into account. Next slide, please. Another study that we did with Kaiser Family Foundation was the racial disparities in testing, infection, hospitalization, and death. Now, overall, what I think is important to note about this one is that non-white, and this would be Black, Hispanic, and Asian patients, had sort of negative, significant higher rates of negative health outcomes across the board when we looked at COVID. This graph that you're looking at right here is both the hospitalization and death rate. And as you can see, that Black, Hispanic, and Asian comparatively had significantly worse outcomes. So I'm going to point out a couple of the key findings. And again, if you're interested, go ahead and look at the entire brief. There's lots of good information in there. Hispanic patients were 53% more likely to be hospitalized and 30% more likely to die than white patients. Both Black, Hispanic, and Asian patients had significantly higher rates of infection, hospitalization, and death compared to white patients. Important to note that these differences were not explained by socio-demographic factors or underlying health conditions. When we looked at sort of the testing rate, positivity rate, and level of care, we found that Hispanic and Black patients were more likely to be tested than white patients. Hispanic patients had 2.5 times higher test positivity rate than white patients, and all non-white patients were more likely than white patients to test positive. Both, or actually Hispanic, Black, and Asian patients were more likely to be in an inpatient setting when they tested positive and were more likely to require oxygen or ventilation. Key takeaway from this is situations such as this and some of the other sort of economic and access to care factors that others have spoken about are likely to exacerbate further these health disparities that we saw pre-COVID. So very important when we're all thinking about policies and outcomes going forward to take this into account. Now, I think I'm the last speaker and we'll turn it back over to the host for Q&A.
Thank you so much. Those were really great presentations, and we're already starting to get a lot of questions. So I guess let me start with one question that I think would be good for maybe each of the panelists from IQVIA and EPIC to jump in on. So we're seeing a lot of care had been foregone and it's not necessarily catching up. Do we have a sense of how much of that foregone care is high value care versus low value care? You know, Michael kind of touched on this, that some of that care that was foregone might have been kind of the nice to have healthcare, for example. But then we're also seeing in your presentations that a lot of preventive care, which we know is high value, like immunizations and screenings, was also foregone. Do we have any sense of kind of on net what we're talking about, or what this might mean for kind of the value of the healthcare that people are getting? Michael, looks like you want to go first.
Yeah, so I mean, I think, you know, one of the things that we've looked at is things like rare diseases. We've also looked at cancer. The concern, I guess, is that somebody who is diagnosed and already in treatment not receiving that care would be high value care. And the challenge is for something that clearly has a link between a diagnostic and identification of a patient, where early treatment would give them a much better outcome. Those foregone diagnostics are a big concern. So these, you know, all of those really feel like the high value care ones. I think we've self-selected as analysts towards things that matter. But what we've also seen is that there is a significant and large impact on lots of chronic care that is just below baseline. We've seen some patients in our regular tracking who are more adherent to chronic medications than maybe they were beforehand, but it's not a order of magnitude change. It's not sort of a significant improvement. It's just it's nice. It's just not great. But I think that there are some things you can point to. You know, if your kids are prone to regular ear infections, they're not in the swimming pool, they're not going to get them because the pools are shut. You know, they're not running into all their friends and passing infections around from daycare. So all of those things that are generating some of the large volume antibiotics and other treatments are not happening during that sort of peak period. But, you know, the regular treatment of people who have significant conditions, we've seen them be largely insulated. We've seen that, by the way, across countries. So it's not just a US thing. It's not just an exposure to cost. It is consistent that the health system seems to figure out who's important and get to them. But there are definitely systemic challenges in when you need a patient to turn up, when you need a regular flow of asymptomatic people to find out they have high blood pressure. Those things not happening is a concern for us.
Yeah, I would add that there's definitely a ripple effect to this as well. What we're seeing and going through right now is just the first wave of what's likely to play out over the next, 3 to 5 years as we see delays in care manifest themselves in cost elsewhere. The other element I would add is there's reimbursement questions that follow through this as patients move in and out of different payer channels that can affect not just the patient's access to the medication, but the entire economic model from hospitals on down to individual prescribers and insurers in between.
Chris or Nikki, do you want to add anything? Or
This is Chris. No, I think that was very well stated. Nikki and I have actually spent some time talking this through, and with the other panelists, that the great unknowns that are here. We've all spent some time looking at different aspects of this, but what is, I think, most potentially concerning is that missed care, and we may not see that for some time as these things play out. So it's going to be important to keep an eye on those things, to do the things that we know make a difference up front, particularly the screenings and the immunizations, and then monitor very carefully and use some of the predictive models, the risk analysis tools to, as was said, identify those patients who are at high risk, get them in and engage with them.
Great. So we're getting a lot of questions about the flu vaccination, or sorry, the flu data. So some of the questions are around if there's any speculation about why we're seeing high rates of flu shots. Also, if we know anything about the demographic breakdowns of who's getting flu shots or who isn't, and if there's any way that we can speculate about what this might mean about the percent of the population that's getting flu shots. So I know we might not be able to answer all of those, but if there's any,
I'll take a quick sojourn through this for you. So we know that the IQVIA data that I showed represents about 1/3 of the overall vaccinations. So normally CDC says there's a lot more. They happen in different venues, sort of, workplaces, churches, schools, sort of special events. What we're seeing is pharmacy prescriptions that have to result in a vaccine. So it's a subset. So it's directional, what I was showing. Why are they happening? Because everybody from the provider to the pharmacist recognizes the importance of doing that right now, and everybody's grabbing hold of it and saying, please do that. And that's a real positive in terms of keeping people out of hospital in this time. So there's definitely some buy-in. And we've noted as well, we regularly track the flu here at IQVIA, and I can tell you that vaccination rates tend to be a little bit lower when people think that it's a weak flu season, like the word of mouth gets around and everybody chats to each other. And my mom and her friends will say, oh, it's a weak season, I don't need to. This year, everybody is bought in, and there's a lot going on. Now, in terms of the demographics, what I can tell you we have looked at is state by state so far. And there are generally some strong movements to more across the board, but there are some states that are not as strong or going the other direction. And it's too early for me to say whether that's the sort of the tracking that we do through pharmacies is doing something different, or whether there's something specific at that state level that's driving lower rates. So it's hard to put myself down on a definitive story there, but it's not uniform around the country yet. So I think it's really positive. It's a good sign. It means that we're likely to have a weaker flu season, which will be great for the worries we have about the sort of hospital capacity going through the winter. But that's kind of as far as it goes. The strength of the data is not robust enough to really tell us, super magical things.
Okay. Nikki, you spoke a bit about some of the racial disparities and outcomes with COVID, and you mentioned that even when controlling for socioeconomic status, that those disparities persist. Could you elaborate a little bit more on that and talk about why that might be the case?
Sure. So I think some of the key things to think about with that is when we do a research study such as this and try to control for some of the underlying comorbidities and so forth, what this suggests is that there's probably ways that sort of racism and discrimination may be affecting health outcomes that were not captured by our sort of matching and controlling in this study. Potentially, and these are all potentials, I would urge people to read the entire brief sort of for more detail and discussion on this. And once again, the KFF authors did a great job sort of discussing that as, some suggestions as to why. We do know that prior research has shown that people of color maybe get a poorer quality of care once they're hospitalized. Things like that could factor into why we're seeing more of these negative outcomes sort of through all aspects of COVID while controlling for comorbidities and so forth.
This question I think maybe is for Luke, but others can jump in. You've talked a lot about the payer mix, and Michael's data also showed about how utilization still hasn't quite picked back up to where it was before. What do we think this means for the provider market in terms of consolidation? Will we expect to see more provider consolidation than otherwise would have been the case? Might this also be maybe just accelerating consolidation that otherwise would have already happened anyway? Do you have any thoughts on that?
Yeah, it's a great question. When you think about the economic forces that are driving consolidation, it's basically trying to get more with less because you're protecting your margins. When the system moves through such an economic shock, and there's really an economic shock of what happened in Q2, There was a great report by the American Hospital Association, the AHA, that estimated in Q2 alone they were going to lose about $200 billion in revenue from the cancellation of elective procedures. You kind of magnify that out, and providers who may have had smaller offices or had fewer patients coming through, being shut down for a quarter could be enough to put them out of business, right? And that consolidation, those economic forces really driving an increase in consolidation really at all levels. I think it's likely from the individual provider all the way up to the hospital systems and elsewhere. The telehealth with Livongo and telemed or teledoc also being an example of where there is some recent consolidation as well.
Okay. So now I'll turn back to my KFF colleagues. We've gotten some questions about the insurer filings and also some of the research that we've put out about how the pandemic might have been good for insurers' bottom lines. You know, we've seen that with the decrease in utilization of healthcare, that's meant that insurers in many markets have become likely more profitable, or at least have higher margins and lower loss ratios. We've also seen that some insurers have given out premium holidays, so to speak, or preemptive loss ratio payments. Kritika, can you talk a bit about how this might all balance out?
Yeah, and so like Cynthia just said, a lot of the loss ratios were lower than expected earlier in the year due to the decrease in utilization. And preemptively, what, at least in the individual market, a lot of issuers said it gave is they, ahead of their MLR filings, they went ahead and gave rebates directly to consumers. As plans are going into the next year, I think they are definitely considering this because they're low spending while a lot of folks are suffering during this pandemic is not a great look. And so I think plans are going to continue to think about this, but MLR is a 3-year average. And so their incentives are set up to optimize on a 3-year level. And so we'll see. I think I'll let Nisha talk about sort of what was in the filings, but I think plans definitely considered how the reduced utilization will affect their MLR look.
Yeah,
Yeah,
Nisha,
thanks. I think.
go ahead. Sorry.
Oh, no, it's fine. The one thing I was just going to add on to that was, you know, we did see that insurers were, of course, covering COVID testing costs, but also many insurers were also covering treatment costs. And so that, you know, could also factor in. And the COVID treatment waivers in terms of covering the full cost of this of treatment, you know, those extended into the fall of this year into October, and it remains to be, we have to still see, you know, which insurers will continue covering the cost of treatment, but that also factors in.
And then a kind of related question for Nisha. You mentioned that some of the insurers are expecting that the pandemic will have an upward effect on their costs for next year, and some are expecting a downward effect on their costs. Could you talk about kind of, was it more common that insurers expected an upward effect or a downward effect or somewhere in the middle?
Yeah, it was, you know, it was really all over the place. We saw a whole range of, you know, assumptions being made, and some of it, you know, it depended on the insurer. Some of them were, it was also, there was regional variation as well. And so, you know, I can say that, you know, some insurers, especially, we also have to take into consideration that some of them were redacted, some of the filings were redacted as well. So many insurers, you know, projected an upward pressure on cost, but also many projected a downward pressure overall on costs.
So we're also getting a lot of questions about the vaccine. Maybe these are questions for folks at Epic, but others should certainly chime in. As we move closer to the development of a vaccine, whose responsibility is it to educate Americans on the importance of getting the vaccine, and also how is it going to be distributed? How is it going to be accessed? What might you expect might be different about the vaccine rollout in this case compared to how people normally get vaccinations?
Nikki, is that one you want to take a shot at?
I'll start, and then I'm sure we can both probably chime in on this. Just, you know, one of the key questions I think, or a key part of that question is whose responsibility is it to sort of educate the public on the need for that? I think very clearly it is a lot of people's responsibility. I think we need to do a good job as physicians, the scientific community, the medical community, health systems, government across the board, and really if we can have a unified message on the importance to the individual as well as the greater community of vaccination, that's going to be critical. As far as what the distribution will look like, I think that's to be determined. I think you know, governments, health systems, providers, so forth, have been planning for sort of a pandemic vaccine distribution for a long time. And will those pandemic plans come into play here? Yes, you have states and so forth that are putting together distribution plans right now. All of this is very in flux, is sort of an understatement based on the fact that we don't know if and when and how many vaccines will actually be available for approval. So yes, I think the planning for this is massive and underway. And now I'll see if Chris has anything to add to that.
I mean, I think that was very well said. A lot of uncertainty. That said, there are things that we can all do in advance. Speaking from Epic's perspective, I know that we've had development teams working closely with customers and with government agencies on what types of things are going to be necessary from a technical infrastructure point of view. And it's not rocket science, I'll say that, but there do need to be standards for communication, for tracking of the different types of vaccines, as well as clinical decision support that will pertain to the various types of vaccines, especially the ones with 2 doses. What type of catch-up schedule, those sorts of things need to be taken into account. And then, of course, the infrastructure for clear tracking and reporting. One of the things that at the very beginning of the pandemic became very obvious to everyone is that state by state and differences in tracking and reporting made it difficult to initially get our hands around both the scope of the problem and the response. And so having continued discussions and work on a unified way to track those vaccines is going to be tremendously important.
And another question that I think might be good for you guys to answer at Epic, but folks at IQVIA should also weigh in, I think. How should people make a decision about whether to get care or not? So, you know, we've seen that there's been a drop in utilization. We suspect some of that was because care was canceled early on, but when people are thinking about going and getting care that they think they need, but they're also concerned about contracting COVID, how do people balance that decision going forward?
Well, it's an extraordinarily personal question in terms of each individual having to balance out their perception of the risks, as well as their perception of the value of the care that they are missing. I think the most important thing for individual patients is to stay connected to their healthcare team. There are a variety of different ways that you can do that are separate from an in-person office visit. As we've said here, telehealth has seen a tremendous jump. And that doesn't necessarily have to be a video visit. That's also included just by phone care and other types of non-face-to-face interactions. But I think the most important thing for people is to stay in touch with their care team. And they can get help in that way, assessing those risks. And many times there are options for patients that they might not know about. We've worked with a number of organizations through things like their patient portals that help take a patient wherever they are and walk them to an appropriate venue of care, whether that's a secure message back and forth, a video visit, or something like a face-to-face visit. Doesn't always have to be face-to-face, but it does require that patient be engaged and realize, hey, while the pandemic is going on, the other processes and risk factors that I have don't know anything about that. And so needing to stay in touch with the care team who can help them make those very individual decisions.
And Anyone else want to jump in? Yeah, go ahead.
Sure. I just had one thing to add on there. I think it's very important for people to continue to get their regular preventive screenings, vaccinations, and also just it's important for people to understand that some of the risk factors for a poor outcome from COVID are chronic diseases that need to be managed well during this, right? So it is important for people to stay on top of, and as Chris mentioned, in contact with your care team so that you're taking care of yourself so that you have the best chance of avoiding, and if you are unfortunate and get COVID, of having a good health outcome. So I think that people should just remember that, and if they're concerned, stay in touch with your care team, find out sort of what COVID procedures are being put into place at that doctor's office and so forth, and just to remember that it's very important to care for yourself through this pandemic.
Great. And then one final question, I think, for both IQVIA and Epic. We've seen that utilization has started to rebound. How much of that on both the inpatient and the outpatient side is because of COVID versus regular routine care or emergency care or other kinds of services that people would have been getting regardless of the pandemic? Or is that a question we can answer?
Well, I mean, I think we can answer that COVID hospitalizations are a very small proportion of overall health system utilization. So I think it's about normal stuff, and a return to normalcy is a pretty obvious assertion. So, you know, that's definitely one thing. I think it's also clear that when we look at various public sources of the capacity of ICUs and hospitals in general, they are there are far fewer of them that are exceeding capacity the way we were back in March and April in the first wave. So that's, I guess, a small silver lining in there. But, you know, obviously the cases and the hospitalizations are still at pretty high levels. This is not this is not over by any stretch.
Yeah, the element that I would add to that, Michael, would be when you look at the backlog of patients that need to move through the system, they're trying to move through the system when the system got a little bit smaller, right? So just trying to get an appointment into a prescriber's office or to into the health system, it's going to take a little bit longer now, right? So there's different ways that you can come in via telehealth. So that's a good avenue that's helping address some of the capacity. But we know that there's social distancing and cleaning requirements that are also changing the capacity of patients to be able to move through the system. So I see not only do we have the immediate challenge of getting through the backlog, but how do we get through the backlog when the whole capacity of the system is maybe constricted a little bit more than what it was prior to the onset of COVID.
And I just pick up on that. Maybe this is one for you, Chris, as well, is the idea that we just have to replace every visit with a telehealth visit is maybe not appropriate. There are, younger, healthier people like us who may be able to cope with a telehealth visit, whereas a provider may be able to sort of shove us off onto the interwebs and get a senior in person. And that seems to be anecdotally the way certainly my dentist and my doctor are behaving. So I'm without violating HIPAA. I'm just curious to your thoughts on that.
If you tell us about yourself, no HIPAA violations involved, you can say whatever you want. So we're here for you to listen, Michael.
Thank you. Appreciate it.
You're welcome. No, it is an interesting question. Telehealth is not a one-to-one replacement necessarily. This is an instance in which the sort of long-standing low simmer, I call it, of telehealth is really interesting now, because there's been a lot of small-scale work on telehealth over the years. I think it's still an open question now that the volumes have gone up so dramatically. Well, in which cases can you substitute telehealth one-to-one for which patient populations, as you point out, for which disease states? There are some things that we know telehealth works really well for. A variety of behavioral health related things have been shown repeatedly that is as good or better in some diagnoses and cases than a face-to-face visit for a variety of reasons. But other things, it still remains to be seen. So it is an open question which of those things will be best addressed by telehealth interventions. I think the important thing, though, is telehealth has become a real tool in the toolbox. I think a real option in a lot of cases where it was not before.
All right. Well, We have more questions than we have time to answer, but I want to save the last 5 minutes or so for Jay Want to give some closing remarks on what he makes of all of these presentations.
Well, thank you very much. Thanks to all the panelists. I don't know about the other 600 people on this call, but I learned a lot today. Tremendous amounts of data, and I really enjoyed actually kind of the extrapolations or the speculations that you had during the presentation. I'm just going to try to pull out a couple of things. As I looked at the deck and thought about it in terms of our work here at Peterson, the V-shaped, I think Michael called it shark bite, was really striking to us. We had hoped basically that this was kind of a wake-up call, that the system was ineffective, was inefficient, wasn't reaching nearly as many people, that we could all do it better, basically. But the rapid kind of rebound from the nadirs of the visit volumes was sobering for us. That rebound is good in some cases in the terms of restoring preventative services. Obviously, that's a great buy just in terms of what you want your healthcare system to do. But the question for us was one that actually somebody else brought up very early on was, okay, so the care that's missing, is that high value care or is that low value care? I mean, the experience from the RAND health insurance experiment would suggest that it's probably some of both. But is there a way basically to kind of get the good stuff without getting the stuff that maybe didn't need to happen? We still have hopes for that this is actually a wake-up call for the system to kind of transform, to try to filter through that, to try to find the stuff that is going to be delivered for society value on a long-term basis, while eliminating the stuff that actually maybe shouldn't have happened or was kind of nice to have. I think one of the speakers said. We have noted that there are some payers that have actually used the opportunity to try to move more to population-based payment. We think that that's a system that actually could be beneficial in that regard, of kind of filtering low value care from the high value care and getting it to the people who actually need the high value care. Blue Cross Blue Shield of North Carolina has actually used that opportunity. And we also note that people who have been on population payments did better during that shark bite. But basically, they continue to have revenue coming in, while fee-for-service providers, I think, struggle to a much greater degree. We think that there's still an opportunity out there. I mean, our interest is in the long-term transformation of the system to give better access and also to increase value, basically, for everybody in the system in a $3.7 trillion economy. So we think that opportunity for better or worse is actually coming like a freight train at this point. And it's in one of the slides that somebody put up about Medicaid, that states are now experiencing revenue shortfalls on the order of 8 to 10%, and increasing their roles basically on Medicaid in that same 8 to 10% proportion. That means that we're going to have to get a lot more effective and a lot more efficient in order to be able to do at least as good a job as we've been doing to this point, and hopefully a better job coming out of this. As Winston Churchill said, never waste a good crisis. This is a good crisis, a terrible crisis just in terms of the human toll and the suffering and the 200,000 plus Americans that we've lost. But if it helps us actually get to a system that can provide for everybody better, we are thrilled by the opportunity that it offers for the delivery system and for payers actually to innovate to get us all a system that we can live with. And with that, I will personally thank all the panelists and turn it back to Cynthia.
Yes, thank you all for joining. Thank you to the wonderful panelists for giving such a rich presentation and discussions. And thank you to our audience. We'll be making the slides available online, and as well as a recording for you to see on kff.org. And please continue to reach out with any more questions, and we'll do our best to do some more research to answer them. All right, thank you all and have a great afternoon.